AETCM, the emergency medicine channel. Today we are going to discuss about carbon monoxide poisoning. So it is one of the most common cause of poisoning, and it is known as the second most common fatal poisoning. Can be either suicidal or an accidental poisoning. Okay, and the concentration in the atmosphere is like 0.001% only, but people get exposed to carbon monoxide by burning certain things and all. Okay, so previously the carbon monoxide was released from the old type of vehicles and all. So it was through vehicle emission people get exposed to carbon monoxide, and the peak incidence usually happens in winter when persons are using space heaters or any wood burning stoves or charcoal burning and all. And this carbon monoxide can also be generated from certain generators air conditioners, or from motorboats, or in camp tents and all, whether persons are burning charcoal or wood and all. So in such cases people get exposed to carbon monoxide. And inhalation to smoke. So all these conditions the patients will be getting exposed to smoke. So smoke inhalation is one of the most common cause of carbon monoxide exposure. And methylene chloride, it is usually seen, methylene chloride is used as some bubbling fluids in some Christmas decorations and all. So that can also cause exposure to carbon monoxide, and people will be having carbon monoxide poisoning. And methylene chloride is also seen in certain kinds of varnishes and paint strippers and all. Okay, so the sources, as we already told, it can be from any automotive exhaustive motorboats, or any propane fuel heaters, or any burning of any wood, coal and all. And any structural fires, or patient get exposed to a fire in a closed room, and any gasoline generators, any natural gas furnaces, methylene chloride, and like that. So the pathophysiology is carbon monoxide is actually a colorless and odorless gas, and in urban areas normally the concentration in the atmosphere is less than 10 parts per meter. But if persons are exposed to some occupations, the concentration is little bit high. So in such patients or persons, they are actually allowed to work there only for 8 hours and all. To reduce the exposure to carbon monoxide. So average 50 parts per meter over 8 hours. Beyond that, persons are not supposed to work there. And more than 10 parts per meter concentration is there, then that means that patient will get carbon monoxide toxicity. Okay, so physiologically a person's body will have only 1% of carbon monoxide in a healthy non-smoker. Okay, so that concentration of carbon monoxide is because of lysis of hemoglobin, or in some sepsis conditions and all. So in that case, patient's body will be having carbon monoxide, but it is usually around 1%. But in case of smokers, there will be around 10% concentration of carbon monoxide in the body. And we should know that the affinity of the carbon monoxide towards hemoglobin is 200 times more than oxygen. Okay, and affinity towards myoglobin also. So carbon monoxide is having more affinity to hemoglobin and myoglobin as compared to oxygen. And in case of a child, or in case of an infant, the fetal hemoglobin is having more affinity towards carbon monoxide than oxygen as compared to the adult hemoglobin. And if the carbon monoxide is entering into the blood, 85% of the carbon monoxide will be bound to hemoglobin, that is known as carboxyhemoglobin. Okay, and the rest will be dissolved in the plasma, or it will be getting binded to the myoglobin, or it can be in the intracellular compartment. Okay, and the half-life of carbon monoxide in the body is 249 to 320 minutes in room air. And if the patient is getting exposed to carbon monoxide in an environment where there is 100% oxygen, then the half-life is less. That means there will be only maximum 74 to 80 minutes half-life of carbon monoxide will only be there. And we should note that if suppose this patient is getting exposed to methylene chloride exposure and then getting carbon monoxide poisoning, the half-life of that carbon monoxide is little bit high. That can be up to 8 to 13 hours. Okay, so this is the half-life of carboxyhemoglobin. This is actually helpful when we come to the treatment of carbon monoxide poisoning, because the treatment is with oxygen. So by giving oxygen, we will be trying to reduce the half-life of carbon monoxide and thereby bringing the patient into normal condition. Okay, so as I told, 85% of the carbon monoxide is bound to hemoglobin. So what will happen? The oxygen dissociation curve will get shifted towards the left, and the affinity, since the affinity is too high, the oxygen delivery, nothing will happen. So as a result, patient will go into hypoxia. This hypoxia can cause lactic acidosis. Patient might be tachypneic like that. And the rest 15% will be dissolved in the intracellular compartment or in the plasma or like that. So in the rest of the 15%, what will happen is it will it will go to the cell mitochondria. It will inhibit the cytochrome oxidase. Then it will reduce the cell respiration, will reduce the ATP generation, and it will cause uncoupling of the oxidative phosphorylation, and that will again increase lactate. Okay, hypoxia can also increase lactate, and this can also increase lactate. And in the blood vessels, it will cause endothelial dysfunction, thereby causing vasodilatation in the blood vessels by releasing guanylyl cyclase and nitric oxide, and that can cause hypotension. And it is having other properties, like it will cause it will activate the platelets and it will cause platelet adhesions, and it will increase the degranulation of the neutrophils, and it can also start an inflammatory cascade, and thereby causing lipid peroxidation can be there, and neuronal death. So this is the oxygen dissociation curve. This is the normal oxygen dissociation curve. And in carbon monoxide poisoning, oxygen, this is a sigmoid shape. And in carbon monoxide poisoning, it will be like a rectangular shape oxygen dissociation curve, and shift to left will be there. And the affinity for hemoglobin will be very much high, so the oxygen transfer exchange will not happen. So we told, since it is by the carbon monoxide, as it is binding to the hemoglobin, there will be hypoxia, and because of the endothelial dysfunction and the endothelial binding, there will be hypotension because of the vasodilatation. Okay, and because of the inflammatory cascade, there can be the cascade can cause cardiac problems, brain problems, and also muscular problems. So there can be cardiac myositis can be there. There can be a patient because of hypoxia and everything, patient can develop MI. Then patient can be having some neuronal tissue damage, especially in the basal ganglia. And since it is having the as the carbon monoxide is having increased affinity to myoglobin, there can be rhabdomyolysis also. So clinical features, if the patient is pulled out from a house of fire or a running car or from an accident scene with a lot of burns and all, we can suspect carbon monoxide poisoning, and if such patients are in low sensorium, we can suspect carbon monoxide and treat accordingly. But in case of elderly patients, if they present with syncope or ECG changes suggestive of an ischemic change and all, in such patients it will be difficult to diagnose. But acute presentations can be like this, like a patient pulled out from the house fire, or a patient coming to ER with syncope with ECG changes, or of a patient who lives in an apartment with propane heater coming with a history of headache. Headache can be patient's complaint. Patient might tell a history of headache when patient is at home, and when patient go to work or some other place, that headache relieves. That might be another history. Or patients might be presenting to ER in a coma state, and when we take the ABG, there will be lactic acidosis, which is causing a high anion or metabolic acidosis. So that can also be presentation. And other symptoms are headache, vomiting, these are like mild to moderate symptoms of carbon monoxide poisoning. And because of the brain involvement, there can be ataxia, seizure, syncope. That can be either because of cardiac involvement also. There can be focal neurological deficits. There can be eye and skin changes causing visual disturbances and bullous skin lesions. Okay, and there can be ECG changes showing ECG changes of ischemia or dysarrhythmias, and patient because of hypoxia there can be tachypnea, dyspnea and all. So physical examination, carbon monoxide poisoning, we won't be able to see the cherry red mucosa in all individuals because in darker individuals it not be seen. And when we check the vitals, there can be fever, there can be tachycardia, tachycardia and hypertension might be because of the cardiac involvement, and because of hypoxia there can be tachypnea because of the hypoxia. Because of vasodilatation there can be hypotension, and that can cause respiratory and cardiac arrest also. And some patients initially they might tell the symptoms like there can be mild headache, then later on patient will go into confusion state, irritability, seizures, focal neurological deficits and ultimately coma. And in severe poisoning we can see on fundus examination retinal hemorrhage also can be seen. And in skin manifestations there can be bullous lesions, pressure necrosis and all. And if this patient is taken out from an accident scene or a burn scene and all, we should also suspect trauma and other injuries to the person. So, okay. And in chronic exposure, so we told about acute exposure and acute presentation. In chronic exposure, patient can be having might present with history of difficulty in concentration or any personality changes or a history of memory loss and all. And that is because of the carbon monoxide related chronic neurotoxicity. And patients can have long-term neuropsychiatric manifestations also. So diagnosis. So how to diagnose carbon monoxide poisoning? Okay, so when we check the patient's vitals, there can be tachypnea, there can be hypertension, hypotension, this thing and all. But oxygen saturation might be normal. So we know that carbon monoxide is having more affinity to hemoglobin and that in turn is causing hypoxia, but saturation might be normal. So that is because the wave of the carboxyhemoglobin and oxyhemoglobin is detected is somewhat in the same range, and when the saturation probe is detecting that, it will be detected as normal. So the oxygen saturation might be normal. So in order to diagnose carbon monoxide poisoning, we need to check the co-oximetry. Co-oximetry will tell the total hemoglobin, the oxyhemoglobin, methemoglobin value, carboxyhemoglobin saturation, waveforms, everything will be mentioned. And if there is more than 50% of carbon monoxide, that means there is severe intoxication. And if suppose we are seeing the carbon monoxide level less than 10%, then in such patients, if there is any symptoms of carbon monoxide poisoning, we need to suspect and treat accordingly. So I told saturation probe is unreliable because there is a same wave for carboxyhemoglobin and oxyhemoglobin, so it is unreliable. And we need to check the co-oximetry, pulse oximetry. So when we check the ABG, we will be able to see the PO2 value. So if there is a significant difference between the saturation and PO2 value, that means there is a pulse oximetry gap. So that suggests that the patient is having carbon monoxide poisoning. And in the ABG, we will also be seeing high lactate because of hypoxia and the inhibition of the uncoupling of the mitochondrial cycles and all. And there will be unexplained hagma or lactic acidosis causing hagma. And the creatine phosphokinase will be elevated because of the rhabdomyolysis and muscle injury because of the binding of the carbon monoxide to the myoglobin. And troponins can be elevated because of the cardiac involvement. Then in the brain, like neuron specific enolase or S100B, CNS proteins and other basic protein markers also will be elevated because of the neuronal injury. And we should also suspect cyanide poisoning along with carbon monoxide if the patient is getting exposed to fires in a closed room or structural fires and all. Okay, and we should also, other investigation which we should take is ECG to rule out any ischemic changes. Then if at all this patient is having associated MI, cardiac catheterization might be required. And in the brain, if we are taking brain imaging, we can see bilateral symmetrical globus pallidus lesions and deep white matter abnormalities because of the neuronal involvement. Okay. So that is how we diagnose carbon monoxide poisoning. And suppose if we have a patient with carbon monoxide poisoning, how to treat that? So as I told, we know the half-life of carbon monoxide is almost coming to 250 to 300 minutes. And in a patient who is getting exposed to carbon monoxide with 100% oxygen saturation, the carbon monoxide half-life is very much less. That is only up to 80 minutes only. So the treatment is with oxygen. So the best way to give maximum oxygen is by giving hyperbaric oxygen therapy. So in the hyperbaric oxygen chambers, they will be using almost 2.4 to 3 atmosphere pressure oxygen will be giving, and 100% oxygen will be given to the patient. So that will reduce the carbon monoxide half-life in the body, and that will eliminate the carbon monoxide. But there are specific indication for that. So okay, so if we get a patient with carbon monoxide poisoning, when should we refer the patient to a hyperbaric oxygen center? That is, if a pregnant lady presents with carbon monoxide poisoning, and if we get the oximetric carbon monoxide level more than 15%, we should refer to the hyperbaric oxygen center. If the carboxyhemoglobin level is more than 25% in a normal individual, we should refer. Why in pregnancy this thing is less? Because pregnancy, the fetus is having fetal hemoglobin. The fetal hemoglobin is having more affinity to carbon monoxide as compared to adults. So in pregnancy, we should, if it is more than 50%, we should immediately refer. And in adults, if it is more than 25%, we should refer. And in case of patients with other systemic manifestations like syncope, acute MI, confusion, seizure, coma, and other focal neurological deficits, or ABG showing severe acidosis, high anion gut metabolic acidosis, depending on that, we need to refer the patient to a hyperbaric oxygen therapy center. And other patients like mild toxic features and all, we can observe at home, or if they are asymptomatic, they can be observed at home. And moderate toxication features should be given supplementary oxygen. Either it can be given through high flow oxygen can be given to the patient, and we can check the other lab parameters for the creatine kinase, troponin, ECG. These things can be checked, and if the patient is okay, we can observe for 4 hours, and then we can discharge the patient. And if this patient is having severe intoxication, then as we told, we should refer to hyperbaric oxygen center. And if there is any delay in transfer, we should start on high flow oxygen and then refer to the hyperbaric oxygen center. Okay, so high flow oxygen can reduce the half-life of carbon monoxide to 90 minutes. But if you are giving hyperbaric oxygen, that can reduce the T-half to 24 to 30 minutes. So hyperbaric oxygen will reduce the carbon monoxide half-life more rapidly, so that the patient will resolve fast. Okay. Then in comatose and intubated patients, in such patients we can give 100% oxygen, so that the half-life of carbon monoxide will be coming down. And there is also another way to reduce the carbon monoxide levels in intubated patients that we will discuss after few minutes. Okay. And if we don't have co-oximetry, if we have no other way to diagnose carbon monoxide poisoning, just if the patient is having some symptoms, start high flow oxygen or start oxygen with NRBM if we are suspecting carbon monoxide poisoning. Okay. So, as I told, hyperbaric oxygen therapy is exposing the patient to 100% oxygen under supraatmospheric condition. That means 2.5 to 3 atmosphere to lower the half-life of carbon monoxide to 24 to 30 minutes. And the benefit is maximum if the patient is getting hyperbaric oxygen treatment within 6 hours. And as the time delays, there can be more neuropsychiatric manifestations. And if the patient presents to us with after 12 hours of exposure to carbon monoxide, there is no much point in giving this treatment. Indications we have already discussed. Patients in pregnancy and in other case pregnancy, it is like 15 to 20%. If more than 15%, we can refer, and other cases more than 20 to 25%. And in case of acidosis, MI, neurological manifestations, we will have to refer to hyperbaric oxygen therapy. Okay. And as I told, in intubated patients, we told that we can give 100% oxygen to reduce the half-life. There can be other treatment like we can give a mixture of oxygen with carbon dioxide to intubated patient to maintain a PaO2 of 40 millimeters of mercury. So what will happen if we give both oxygen and carbon dioxide? Patient will go for respiratory acidosis. So in such patients, we will be giving both, and we will be simultaneously monitoring the ETCO2 and the PO2 value to target a 40 millimeter mercury of PO2, PaCO2, and this is by increasing the minute ventilation or keeping the respiratory rate high, because we don't want the patient to unnecessarily go into respiratory acidosis. So we will keep the minute ventilation high, then we will give a mixture of oxygen and carbon dioxide. The advantage is that it will double the carbon monoxide elimination in cases of as compared to hyperbaric oxygen therapy in carbon monoxide poisoning patients. Okay. In special population. So special population, I told children and in pregnant ladies, the fetal hemoglobin is having increased affinity and increased metabolic rate. So that will cause a rapid poisoning and toxic manifestations. And pregnant lady also we told the same. And in elderly, carbon monoxide can cause arrhythmias, CADs, ischemic changes and all. And this is mostly seen in winter. And the prevention is to reduce the use of charcoal or wood at home, adequate ventilation at home, avoid closed rooms, avoid exposure to fire or any charcoal or burnings and everything in closed spaces. Then check for warning signs of carbon monoxide exposure and to keep carbon monoxide detectors at home and fire department. Okay, that's about carbon monoxide poisoning. Thank you.